I welcome Dr. Mohammad Nawaz for the next talk. He is a consultant intensivist at First Neuro Hospital, Mangalore.
Okay. Good morning, everyone. So I'm going to talk about difficult airway management in the ICU. So this is unwinding the airway when you are really unwell. Elaborate this thing. And greetings from First Neuro Hospital, Mangalore. And introduction and problem statement. Basically, intubation is a high-risk procedure, especially in ICU patients, because most of these intubations in ICU, they can be associated with death or permanent neurological damage compared to operating room. So when it comes to patient factors, remember all patients in ICU are physiologically difficult airway because they have limited reserves because of their primary disease process for which they are in the ICU. So we have first part, airway assessment is important in these patients. Most of them will be at risk of aspiration, be it pregnant patients, be it patients with abdominal disorders, or patient who has come very recently with a trauma who might have full stomach. So I'm not going into the details. These patients can also have difficult anatomy, which makes them anatomically difficult airway as well. These patients are prone for hypoxemia and rapid desaturation because of pulmonary conditions or other related conditions. They probably frequently have metabolic acidosis or any other metabolic encephalopathies or metabolic disorders. Most of them in neurological disorders, they can have raised ICPs. Liver disorders, they can have coagulopathies. Many patients in ICU will be hemodynamically unstable, so again, the reserves are low. And most of the time, when these patients are sick and they need an airway, reversing them is not an option. So once you go ahead, you are starting a process of intubation, you have to intubate. Now the challenge is also not just patient ICU related factors where patients, you have limited space, you might not have all the devices that you have in the OT, and the timings, it might be very odd. Maybe night 2 a.m. you might be called for an intubation and you have to intubate. So it might be stressful to intubate at that point of time. The training level of the intensivists, many ICUs may not have intensivists at all the time. They might not have enough experience or the stress levels are probably high, so the thinking is not very clear, so you might tend to do mistakes. Now, how to predict the difficult intubation in ICU? This is a validated score called the Makocha score, where a Mallampati score and obstructive sleep apnea gets a higher score, whereas the reduced cervical spine mobility, mouth opening which is low, the patient is on coma, hypoxemia, or a non-anesthesiologist intubating, all get a lesser score. Anything less than 3, we might think it's an easy intubation. More than 7, 8, difficult. Around 12, very difficult intubation is expected. So you can also use your routine scores like any other airway score you use, or Lemon where you look externally. I won't go into the details. Whichever you use regularly to assess airway, you can use it in the ICU too. But Makocha score is more validated. Now the special consideration while actually doing the intubation, first thing is we spoke about co-pilot some few talks before, presence of 2 operators. It is always important that there is someone with you when you are managing difficult airways or a physiologically difficult airway in the ICU. Calling for help should be anticipated early, and the staff at least has to know that if when you ask for it, they should know whom to contact immediately. Best is do the procedure with another person with you. Pre-oxygenation and peroxygenation or peri-intubation oxygenation is also important. Many of these patients with lung disorders, you cannot really pre-oxygenate for a very long time because they will desaturate earlier in spite of long pre-oxygenation. So 3 to 5 minutes is enough. Hemodynamic stabilization should start even before your intubation consideration. You should make sure the BP, the fluid levels, the BP is maintained with the inotrope. Enough fluid is given. Now that you have ultrasound, and other advanced hemodynamic monitoring, make sure your patient is adequately resuscitated so that you will not have a intubation time arrest. The selection of right pharmacological agent, again, you can choose from variety of agents that you use. Many prefer ketamine. Some of us use propofol. Some use etomidate. We'll not go into the details. We will discuss it if required in the end. Device selection, again, we have now video laryngoscopes, which are known to reduce intubation times, or device selection, whichever you are comfortable with, which you use regularly, and not try using a different device which you have not used before in stress situations. Then comes a rapid sequence induction. Almost all ICU patients are induced with the rapid sequence induction with cricoid pressure. And the variety of controversies regarding cricoid pressure I will not go into. How to give cricoid pressure, is it really necessary? But rapid sequence induction can be done, and there's also something called as a delayed sequence induction which we do for a ICU patient, where some patients it will be very difficult to pre-oxygenate them because they are very restless. So you give a small agent of a hypnotic, make sure you pre-oxygenate the patient well, and then go ahead with the full induction so that you buy more time. Human factors, again, we discussed just now, and intubation bundle. Basically, intubation bundle is you have a ready algorithm. It is already found that with other studies that having a proper checklist and having a proper bundle will allow you to intubate faster and not linger around and waste time at each step. This has been one of the so-called bundles or preparation bundle from Royal College of Anaesthetists. So remember, prepare the patient, reliable IV accesses, optimum position. Now we have a sniffed position, you have a ramped position. So make sure your patient is adequately positioned. Take time for this step because this is one of the most important steps. And ramped position also involves giving a good head end up so that you are compensating for the reduced functional residual capacity in these patients. Now pre-oxygenation you can do with bag and mask. Now considering that we have CPAP, NIV, you could use NIV for optimal effect. You can use high flow nasal cannula. You can use a combination of NIV plus high flow nasal cannula. So all these are methods. Optimize patient state I just spoke about. Make sure is a patient at risk for hyperkalemia, so avoid using agents like saxamethonium. Equipment, prepare all the equipment you have. Have an airway card. Even in your ICU, make sure you have all the relevant things. I use bougie. We have bougie kept in the back, stillets if required. Video laryngoscopes if you have. Make sure all these things are kept. And also advanced airway sets like if you need front of the neck access, if you have a cricothyroidotomy set or a percutaneous tracheostomy set, it might be useful. Please check your drugs. Make sure you have all the things necessary before you go on to the next step. Preparing the team, where if you have a colleague with you, that's best. You make sure you have discussed the plan beforehand, that what will you do next. If you have staff, give them the roles properly, that what each person is going to do. Calling for help, it's not something late. It should come all throughout this algorithm at any point of time. When you need help, call for help, don't wait for it. And what will your plan be if you're not able to secure this airway? Now, there is a double setup approach for difficult anatomical airway if you have, or patients where you expect difficulty, significant difficulty, where one team is ready for the intubation, for putting a supraglottic airway device or any other intervention necessary, but another team is ready with the front of neck airway set so that you don't waste time trying to secure the airway. So if you fail, you can immediately initiate a scalpel cricothyroidotomy or a needle cricothyroidotomy. Now, if you go stepwise approach, this is All India Difficult Airway Association algorithm which I'm using. Call for help comes very early in this. You do not go in the, it's not a very stiff protocol that you go along the pathway. If you have difficulty at any step, you can bypass the steps and go to the higher steps. Step one, what we already discussed, pre-oxygenation and induction of anesthesia, where you need adequate number of people, adequate pre-oxygenation where we can use NIV and CPAP also. Here, cricoid pressure is recommended. Now, for the lack of time, we'll go faster, but the only thing is, I've already discussed these steps. Some of these are evidence-based and given in the guidelines. Once you have adequately pre-oxygenated the patient, and this is a patient who is well resuscitated, now you try for face mask ventilation. If it's successful, you have time. If it's unsuccessful, you go directly for intubation, or you can also, the call for help step comes right from here. You can also call for help and make sure you have additional help at this point itself. Now, if you're able to ventilate, well and good, you can confirm, you can go ahead with the intubation. So, and in between the attempts, when you can't intubate, if you're going to make more attempts, please make sure the patient is at least insufflated with oxygen at this point of time. Now, we are not able to intubate, we go for the next step, which is supraglottic airway. So the second generation devices are preferred, the Procil LMA or the iGel. If you're able to ventilate with the supraglottic airway device, you can use via the supraglottic airway device, try to secure a tube later after the patient is well ventilated. Next thing is, you can either go directly for a percutaneous or a surgical tracheostomy. Now you fail in supraglottic airway, you go back to rescue ventilation again, you continue ventilation as much as possible. If not, go for surgical or percutaneous tracheostomy. Now, what makes you really fast is not trying to do things fast or in a panicked situation. What makes you fast is not hurrying things up, but knowing what to do next. So this part comes in your planning itself. If I fail in this, I will do this next. Please don't linker around and try to do something again and again. Again, madam yesterday would have spoken about, Sumulata ma'am, who's the president of IDA, she spoke about the vortex approach. So you try one device, you can't do it, change the operator or change the device. Don't keep trying the same thing again and again. Go for the next step so that you try to minimize hypoxia as much as possible. So percutaneous and tracheostomy. Now another thing is, I don't know, but if whether all anesthesia colleges and departments make sure all anesthetists should know how to do a tracheostomy. So when I have a colleague with me, I know that if I fail, he should be able to put a tracheostomy himself and not ask for additional help where you need ENT, you need a surgeons to come. The anesthetist should know how to do a tracheostomy, not just even if you are not trained in critical care. Anesthetist herself should be able to do a tracheostomy themselves. So that is about having somebody who will do a definite airway when you fail at everything, or you reach a cannot intubate, cannot ventilate scenario. So other comes emergency cricothyroidotomy. Now kits are available, sets are available. Another thing is, you can always, before starting the procedure, use your modern technology like ultrasound and mark your cricothyroid membrane and make sure you are ready for a difficult airway when required. And once the airway is secure, you should always make sure you have a further plan for airway management. Specifically, if you have inserted a cricothyroidotomy or anything, you need a definite area. You can't keep a cricothyroidotomy, you'll have tracheal stenosis, other complications. So you need to ventilate the patient with the tracheostomy. Other things is treat airway edema if suspected due to our increased handling, monitor for complications, and counseling and documentation are always to be done. And these are the references. I'm showing you more specifically if PGs are there here. Just the guidelines are there in the airway guidelines itself. And the detailed explanation of various other physiologically difficult airway and what is the physiological difficulty is mentioned in the third study. And there are all the evidences are mentioned in the fourth study where you have what is recommended and what's not. Even the IDA guidelines itself will tell you what are the recommended things and what is the recommendation based on. Thank you very much. It's been done brief so that I can finish in time. Thank you.
Thank you very much, Dr. Nawaz, for this excellent and rapid review of a very important topic, because physiologically difficult area, you may not get a second chance. So don't wait for seconds when each second counts. We'll look forward to seeing you in the interactive session again. Thank you.